Hello, hello, and thank you for being bold to join us in our session, our second session, which is going to look at ethics of safety, reliability, and patient protection as we think about artificial intelligence in radiology. In this session, we're going to listen to 3 talks and 1 keynote speaker. I'm going to introduce the first keynote presented by Dr. Melissa McCradden on ethical obligations for safety, reliability, and patient protection. A brief bio of Dr. McCradden is that she is a bioethicist at the Hospital for Sick Children and a project investigator with the genetics and genome biology at the Peter Gilgan Center for Learning and Excellence. She co-teaches empirical bioethics as an assistant professor at the Dalla Lana School of Public Health. She holds a PhD in neuroscience from McMaster University and a master's in bioethics from the University of Toronto. She was the inaugural postdoctoral fellow in the ethics of AI in healthcare with Sick Kids and Vector Institute. And she is an active participant in a number of reporting guideline initiatives, including Consort, Spirit, and Decide AI. Her research focuses on pediatric bioethics and ethics of healthcare technologies with a focus on algorithmic injustice, evidence-based clinical evaluation of healthcare machine learning, and equitable involvement of children and youth in AI research. Welcome, Dr. McCradden, for your keynote presentation.
Thank you so much, Judy. I'm really, really glad to be here. Thank you so much to the organizers for having me. This is a topic that I'm very, very passionate about, looking at patient safety in the era of introducing AI into the clinical space. So what I'd like to do today is talk about patient safety from a number of different perspectives. The first would be responsible evaluation. So choosing the right paradigm for establishing knowledge about safety. The second is from the perspective of justice and fairness. So safety for whom? And then looking finally to promoting a culture of ethical safety in the ongoing use of AI in the clinical space. So first, we need the right kind of evaluation when we're looking at AI. I think it's a pretty well-recognized phenomenon at this point that we know that in silico validation is just not quite enough for a space like healthcare. And in the past, we've seen, a number of excellent model performances in silico where we have curated data sets, we have cleaning that happens in pre-processing, and we can get really stellar performance in this historical space. However, your live data stream looks a little bit more like this. And so certainly we know that there are more issues that require reconciling to really establish some reliable model performance in a complex and live environment like healthcare. And so I think the widespread recognition in the field at this point is that we need to have not only technical validation, but also clinical evaluation as well. And so responsible evaluation needs to be more than just accuracy. Some commentators have noted that there's sort of an interesting clash of cultures that is happening. So we all agree that evidence is needed to support the use of AI in healthcare, but where people differ is what constitutes evidence and how to go about getting it. So from a machine learning perspective, there's a lot of focus on algorithm development and technical validation. And certainly that's incredibly important because we know that AI is subject to limitations like confounding, underspecification, and things like that. And so we need to make sure that we have addressed those concerns during the technical stage before it even moves to a space where we are evaluating it in a clinical environment. But then really focusing on how that clinical evaluation is done to really verify that we have not only established a certain base level of patient safety, but also that the system is providing a net benefit to patients and to the healthcare system at large. And so really, we have this idea that we have these novel interventions and they have a lot of theoretical plausibility. They have a lot of promise to augment healthcare. But we need to cross this bridge over to a place where we know that they're going to bring patient benefit, where they're contributing to the medical knowledge system, and where they're demonstrating reliability. And clinical evidence is the way in which we cross that bridge. So part of this is because we know from other areas of medicine that good technical performance doesn't always translate directly into patient benefit. And I think one of the most notorious examples in this regard is population level advanced screening for certain kinds of cancers. So we know that when these sorts of initiatives have been implemented and scaled up to a population level, we have increased healthcare spending, increased patient anxiety, and generally it's low value in a number of contexts. However, when screening is more targeted and specific to populations in which that screening has been demonstrated to show benefit to patients, there's a lot more that we can do, and there's a great more value that we can get out of that technology. There's another interesting paper that came about recently focusing on this phenomenon called diagnostic downshift. And this is something that I think we have to really keep in the front of our minds right now. And they consider that diagnostic downshift is something that happens when we try to take specialist level care and implement it in a non-expert context. So primary care, for example, or outpatient clinics, emergency departments, and things like that. And I think this is a really interesting issue, because when we talk about equity in AI, a lot of what we are hoping to do is provide certain types of care that don't exist elsewhere to people who might be in underserved areas. And so as we go about doing that, I think we have to bear in mind these concerns about diagnostic downshift, because the authors note that very often this can be associated with low value testing or test indication creep, where the circumstances under which the test was evaluated no longer are how clinicians are using that test, and they may be extending it more broadly. And part of this is because if a test is there, there's a lot of pressure to use it. And very often clinicians will feel not confident in their own clinical judgment, again, knowing that this is a specialist test, and will defer judgment to these sorts of technologies. And so a number of initiatives recently have also shown that some of our really well-performing algorithms may actually just increase workload without actually adding value to patient care. And this was a number of studies that were shown recently. And then one of the other things that we also have to consider is we hear a lot that, AI machine learning doesn't introduce a substantial deviation from the standard of care because clinicians still retain decision-making authority. However, in other contexts where we presume certain technologies by and large are low risk, can be ethically vulnerable. And the references here are to a randomized trial of an e-alert that was utilized at a number of different hospitals. And they found that actually there was a higher mortality rate in the intervention arm at particular hospitals, which was particularly concerning because the IRB in this case had actually waived the requirement for informed consent. So really, I think that we need to look at the specific use case in front of us and really focus on well-designed trials to try and identify that benefit. And it's really important that we do this study because patients are owed a duty of care when they cross the walls of a healthcare institution. And the duty of care stems from this notion that physicians, traditionally physicians, have a specific knowledge set that can be used to improve patient well-being and their interests. So this is linked with the principle of beneficence. And so we stress a certain level of competency with clinicians because patients are owed a certain standard of care. We need clinicians to be aware of the evidence that is out there to support the best available options that they can provide to their patients. And this is certainly context dependent. So the standard of care will depend on where a clinician is situated, what resources are available to them, and the context in which they're exercising that judgment. Now, clinicians also have a moral commitment to participate in activities that advance medical knowledge and improve patient care and public health. So, for example, research and quality improvement activities. And this actually creates a bit of a tension with their obligation to provide the best available care. So if clinicians are always trying to provide the best care, but they know that actually this new technology might be better, but they don't necessarily know, when are we allowed to subject patients to something that we don't necessarily know is better than what we're offering them right now? And this is something that has long been considered in the field of research ethics. And so, of course, as we all know, research ethics, initially stemmed from human experimentation during World War II. However, we continue to have contraventions of research participant interests or patient interests up to the present day. And so research ethics oversight really is charged with the protection of patients and public interests, which is really important because it is certainly reasonable that investigators are trying to advance a novel technology. And so we need that independent oversight that enables us to reconcile that need to innovate with the need to protect patients. And when we look at how the public feels about research involving AI, many of them quite frequently point to research ethics or IRB oversight as a condition on which they would endorse the use of their health data for research purposes. So there's a lot of confidence placed in research ethics oversight. Additionally, clinician researchers also point to research ethics oversight as a means to help them reconcile those competing obligations that we spoke about earlier. So being able to adhere to a given protocol, enabling patient choice, and relying on consent to participate in research are ways that clinicians can reconcile those competing moral duties. And certainly it's been noted recently that ethics review processes require adaptation for novel methods. And Effie Viana in particular has done some really interesting work in this area, looking at what are the novel challenges of AI and big data research, and what are the things that we need to keep because they are the foundation of good research practice. So one of the ways that we've tried to adapt to this novel technology at SickKids is to create, between the Research Ethics Board and our data science team, as well as myself, we've created this 3-stage pathway that enables, it is specifically geared toward the translation of beneficial AI tools. And so it starts with the initial stage of data exploration. So we grant protocols to researchers who want to access a number of different data sources and explore multiple hypotheses simultaneously. We've also embedded into that governance protocol a technical validation or silent trial or shadow trial stage that enables researchers to test initially at least the technical or ecological feasibility of that model in a live environment. And then we provide guidance for moving to the 3rd stage, which is prospective clinical evaluation. And this can take a number of different forms, all the way from an observational trial to a full randomized control trial. And we thought it was important that we look at clinical research because when we compare the other methodologies, such as QI, which is typically utilized when we already know something is in a patient's best interest, whereas clinical research allows us to develop new knowledge about what works and what doesn't work, and to provide the assurance in the methodology that allows other centers to know that if they apply similar approaches, that they could similarly achieve patient outcomes as part of a research study. And so really this process, we think, provides that necessary foundation to establish the kind of reliability of the system that we really care about, which is in relation to a patient-centered or other goal, rather than just the technical performance of the system. And one of the things that I think is really, really interesting and exciting about AI systems is that rather than a singular intervention like a drug, for example, the implementation of AI is prompting us to zoom out and look beyond it just as an intervention in isolation. So a group at Stanford, for example, has this nice paper on a delivery science of AI, looking at how multidisciplinary teams can be of an immense value in elucidating the larger socio-technical systems in which these AI systems will be integrated. And so even contributions from human factors or user-centered or values-based design, implementation science, and a number of other fields are really demonstrating their relevance for not only providing better context for understanding how to implement AI, but for better designed clinical trials that might provide more useful knowledge. And that's key to preventing research waste, because certainly we don't want trials going on without a good moral justification that they may be of value to medical knowledge and social value. And Madeline Claire Ellis, who worked with the team at Duke, has really pointed out how in fact social and interpersonal factors are key to realizing benefit, but they're typically underappreciated by many in the team. So she particularly points out the contribution of nurses to sepsis watch in being the ones who are communicating model outputs to the treating team. And I originally heard this quote from Jenna Waynes, but I think it's more prevalent now, that AI is a team sport. And so I think that we need to think really carefully about who is included in that team, because I think for many of us, it's no longer just there's a data scientist and a physician who wants to implement. There's a much larger team, including all of those fields that I just mentioned. Now, importantly, we really need to think about safety for whom. And so certainly, I think we're all aware at this point of the notable fairness concerns that have been raised in the context of discrepant algorithmic performance as a function of different patient identities. So Ziad Obermeyer's work, I think, needs no introduction at this point. This was the seminal article that I think really brought this to the forefront, where he and his team demonstrated that a commonly used algorithm in the US was referring Black patients to a beneficial complex care management program at the point when they were twice as sick as white patients. And so Ruha Benjamin has a really excellent commentary that accompanies this. And I think one of the notable things about the algorithm that Obermeyer and colleagues explored was that the developers were aware of the potential for racial bias. And so they actually removed patient race from the inputs to the model. However, because the problem formulation was based on the amount of healthcare expenditure, and we know that we generally spend less money on Black patients than white patients, those patterns of bias were replicated in the model outputs. And so Dr. Benjamin points out that very often we juxtapose this objectivity of computational solutions with human bias. So very often people will say, humans are biased, clinicians are biased. And so if we just get a large enough data set, we can objectively model a given phenomenon. And I think Dr. Benjamin really cautions us against that. And I think that's really important because algorithmic bias, in fact, is a little bit of a misnomer. So because algorithms are picking up on these patterns and have this discrepant performance, it means that those patterns were already there to begin with. They were within the medical system, within the medical knowledge system that we're relying on and that is serving as inputs to our AI models. And one of the ways that this came up quite recently was this really, really insightful and striking paper in New England Journal of Medicine, where the authors noted how many clinical algorithms currently use inappropriate race corrections that pose immense equity concerns. And so it's really important that we're bringing these to the forefront, that we're not assuming, we should neither assume that the status quo is either neutral nor irrevocably biased, but really thinking about what are the outcomes that we need to be working toward in this space. And so one of the things that I've been thinking about a little bit lately is whether poor performance or lower performance of a model is necessarily a harm per se. So when we typically talk about algorithmic bias, very often people couch this under non-maleficence, so our ethical obligation to prevent harm to individuals. However, I'm not necessarily sure that having discrepant performance is always necessarily a harm. And that's not to say it's not important, it is important. However, when we talk about harms in the context of a model output, we are effectively displacing people as the subjects by which we define harm. So typically something has to happen to an individual in order for a harm to occur. For example, if someone's pulse ox monitor slips off, there is an output that says there's no oxygen here, but a patient hasn't actually been harmed unless on the basis of that, we then ventilated them. So one of the other pieces of evidence is that in Obermeyer's paper, they actually pointed out that when the researchers examined the predictions that were made, the simulated predictions by the algorithm and the actual rates of referral of Black patients, they noted that physicians appeared to be referring more Black patients into the program than would have been referred by the algorithm's predictions alone. And so clearly something was happening here. Physicians, whether knowingly or unknowingly, were actually redressing some of the observed algorithmic bias. And so when we think about not only trying to improve the performance of systems, which is certainly a notable goal, but if we think about what can we do at the point of care as well, we can promote this awareness of health determinants, because clearly they are powerful as they're influencing the patterns that get replicated in AI. And we can actually center these factors in a clinical encounter. Whereas right now, I think it's a little bit variable in terms of how aware clinicians are of some of these things. And awareness is a first step toward advocating for fairer structures. And really those structures are what are needed to sustain a level of fairness that really translates at a population level to traditionally underserved individuals. And so instead of thinking about AI systems in terms of harms, I tend to think about them in terms of distributive justice. So distributive justice is an ethical principle that's often attributed to structures or policy or law systems that affect everyone. And so what we ask in this context is, are the benefits and burdens of this system distributed equally? And this allows us to do two things. The first is how we might address a currently unfair distribution. So this is where a lot of the algorithmic fairness work may come in. So we can augment a training set by diversifying the training data. We can recruit individuals who are typically underrepresented. We can make adjustments to the algorithm itself. We can modify the thresholds at which predictions reach the clinical team. And so we can look at all of these things as potential to increase the system's ability to provide a fair and just distribution. But if we can't, distributive justice also says, well, that's not the end of the story. We can look at how we can redress some of these harms. So if the system isn't going to perform as well, and there's nothing that we can necessarily do about that, we can address things at the point of care. And we can bring a certain awareness to the point of care that really facilitates a fairness for patients themselves, rather than focusing solely on the algorithm. And the thing is, how we adjudicate between the different approaches, what we actually choose to do, is fundamentally an ethical endeavor. And so my colleagues and I explored some of these issues of when and how to correct algorithmic fairness corrections with actual fairness to patients. And so we found that decisions about bias and what to do with it really require two axes of consideration. And the first is epistemics. So what do we really know about these patterns? Why are they happening? Why are they there? And I think this is where we have a specific obligation to reach out to individuals who study the intersection of race and medicine, who study intersectionality, and really have far more experience than many of us can gain if we're not actually immersed in that field. And secondly, we have to think about the empirical side of things. So how are we going to evaluate the model? How will its outputs be recorded? So if we correct a model that might be offering overly pessimistic predictions of individuals who have low socioeconomic status, then we might record all of these decisions that might say this patient will benefit. However, if the patient still lives in a non-ideal world, the reality is not necessarily going to line up with what the algorithm is projecting will happen to the patient. And so do we record that as an error? Because if we do, then the feedback to the model is that it was wrong, and then we're moving back into reinforcing that unfairness. And so we have to think about this really carefully in the context of the specific problem that we're trying to solve. And I think it's really important to stress that fairness itself is not simply achieved through model performance alone. And this is something that Dr. Benjamin really stresses. And she says, beware the veneer of technical neutrality. So she cautions us against thinking that we can offload concerns about fairness and bias to computational systems, which have historically not served well the interests of those who are underrepresented. And so finally, looking to the last piece of safety here, which I'm calling ethical safety, is where I think we can bring in a relational ethics lens to really augment care with the use of AI. So I'm sure it needs no convincing here, but medicine is a highly complex system. And Paul Cilliers has said that where we have complex systems characterized by uncertainty and incomplete knowledge, it is inherently a normative domain. It is inherently a domain where we need good ethics, because we might have the perfectly performing system, which in itself is unlikely, but there's a larger context as well that we need to consider, where the moral rightness and wrongness of our actions doesn't just come down to a single output of one system. And so a lot of the dialogue right now you hear offers this sort of dichotomous perspective of AI predictions. So are they right or wrong? And subsequently, we're now recording clinical decisions themselves as being either right or wrong. Or sometimes we'll say, if the algorithm output was this, on what grounds can a clinician deviate from that algorithm output? And so there's sort of this positioning of AI outputs against clinical decisions, which I worry underlies a sort of algorithmic paternalism that can potentially compromise the safety of patient values as a balancing axis within that decision-making context, and potentially undermine the value of appropriate clinical judgment, because we know that clinicians are accountable not just for the moral goal of accuracy, but of acting in patients' best interests. And machine learning researchers themselves are raising concerns about this, talking about over-reliance on algorithmic solutions. So we're seeing more and more that we may be acting on incorrect outputs, and explainability does little to actually help with this, such as in Maya Jacobs' paper here. And so what we really want to make sure is, as we're moving AI into the clinical space, we don't want to go from the previous era of doctor knows best into this era where it's AI knows best. And one of the ways that we can mitigate against that concern is by really thinking about the knowledge contributed by AI systems as being only one axis of knowledge in a larger picture in relation to a clinical decision that needs to be made. So for example, Maya Jacobs and colleagues have this really excellent paper where they have a simulated machine learning model that is designed to predict on the basis of minimizing dropout risk. And so we know clinically that risk of discontinuing antidepressant medications is certainly part of the patient encounter, as the authors themselves have articulated. And we know also that antidepressants are typically prescribed according to patient values, such as desire to avoid particular side effects or specific presentations. And so really that notion of dropout risk is only one axis in a larger picture. And clinical decisions, particularly in this context, and let's say in ICU more so than perhaps in a diagnostic system, they're not made solely on the basis of biological, physical, or medical information that is supplied to clinicians. We really have this dual axis of medical knowledge meeting patient knowledge about their lives, their values, their beliefs, and that comprises this shared decision-making model where we respect patients' knowledge. And so moving to relational ethics as a means to promote relational safety points us toward really making sure that we take that knowledge seriously from patients and their values. And relational ethics more broadly stresses a focus on the disadvantaged within a power relationship. So in this case, this is patients and families, and particularly marginalized ones. And I think that relational ethics can really support this culture of patient safety by reinforcing our commitment to have evidence to support AI use, centering patient benefit rather than accuracy and performance in the rationale for the use of a system. And as Abiba Barani points out, it also makes us aware that we need to remain vigilant to constantly questioning patterns and trends that may underlie algorithmic predictions, rather than becoming complacent and being subject to automation bias. We also need to address the power imbalances that may be exacerbated by AI. So even a reliance on something like explainability continues to center the model's rationale for outputs rather than the clinical rationale of the clinician who is providing reasoning to the patient about why they're recommending a course of action versus another. And really what this involves is centering the moral commitments of clinicians in the decision-making space. So fostering ethical safety really means not overgeneralizing AI's contribution to the decision-making space. Let it do what it is really good at and remain cognizant of the larger picture, because it's not just about right or wrong when making decisions for other people. It's about making morally good decisions in a highly complex system. So just to recap, I've argued that clinical evidence provides the relevant kind of reliability that complements a fulsome technical evaluation. Thinking about distributive justice allows us to deliberate about the distribution of benefits and burdens without actually displacing people as the relevant focus of harms. And centering the moral commitments of clinicians to promote patients' best interests and welfare can mitigate against over-reliance on AI and promote a culture of ethical safety. And I think that these are key to this vision that we have, most notably by Eric Topol, where we really want to use AI to make medicine more human. So thank you so much. I really look forward to the other panelists and to your questions. Thank you.
Awesome, very, very good presentation. I can't wait to unpack some of this in the panel session. And so if you have questions, please use the Slido link to ask your questions. And now we're going to go on to our next presenter, who is Dr. Kagen. So Dr. Kagen is going to be speaking to us about ethics of AI implementation from an industry perspective. And he is the co-founder and the chief medical officer of NINES, an AI-powered radiology as a service solution. So Dr. Kagen is a recognized authority in the field of body MRI and is ranked one of New York's top doctors since 2019 by New York Magazine. He serves on local, national, and international committees and has lectured both nationally and internationally on imaging of liver disease, prostate, and gastrointestinal and pancreaticobiliary MRI. He has multiple peer-reviewed publications and has research interest in artificial intelligence and machine learning and specialized MRI for perforator flap reconstruction mapping and lymph node transfer assessment in the setting of lymphedema. He was the past chair of the Radiology Pathology Working Group of the American College of Radiology LIRADS committee and a member of the ACR magnetic resonance PIRADS, that's a classification system for prostate imaging. And he received his medical degree from the College of Medicine at SUNY Downstate Medical Center, where he also completed his residency. And after fellowship, after medicine internship at Lenox Hill Hospital, he is trained in body MRI from Johns Hopkins in Baltimore. Welcome, Dr. Kagen. Look forward to your presentation.
Thank you so much for the introduction. It really is my pleasure to be here. I'm very humbled to be alongside this distinguished panel. A special thank you to Dalla, Dr. Larson, Dr. Recht, and others for inviting me. A little background on myself is I wear two hats, as my dermatologist likes to protect my head. So with one hat, I work in Mount Sinai as site chair of two hospitals on the west side of Manhattan, working under Dr. Dreyer, Dr. Mendelsohn, and our team there. And for today's talk, I'm wearing my NINES hat as chief medical officer and co-founder. Along with David Stavens, some of you, at least on the West Coast, may know that David co-founded the team that became Waymo, so obviously big into image-based machine learning, and the online education company Udacity. And so we're both excited to be at NINES because we really are making an impact on healthcare with AI right now. And so the goals for today, we're going to discuss NINES' approach to AI development and implementation, review ethical data curation and labeling, highlight some real-world examples of our tech stack in practice, and examine how we safely handle patient data. So here are some of my obvious disclosures. So at NINES, our DNA is really as a tech company building software, and we've now evolved into a radiology practice that the goal is to unify medicine with technology by building the most efficient medical diagnostic cloud powered by AI through vertical integration. So we own the interfaces, have control over the diagnostic platform, the engineers ship code daily, control the full machine learning development pipeline, are constantly building out our technology stack, and have 2 FDA cleared medical devices. So let's summarize, how we view kind of the varied approach to how AI is entering the marketplace as we speak. kind of the traditional approach is to develop fancy AI model, get FDA approval, give it or sell it to customers, and then work on something else. And kind of as this harmonizes well with what Dr. McCradden said. We believe that radiologists, to quote Dr. Langlois here, radiologists who use AI will replace radiologists who don't. And it's really about the teamwork and side-by-side approach of having world-class radiologists in the forefront, really working with expert engineers to build tools that they need with extremely close feedback loops, careful monitoring of algorithm performance, and ensuring that what we build actually provides immediate, real-world translational value. So instead of just building an algorithm a few times and then throwing it over the wall to a clinical team, we're constantly monitoring performance, adjusting and tweaking as we go, as per what is allowed for regulated products. But for other software and interfaces, that is the goal. So let's look at how we ensure data set integrity in 3 ways. So at Nines, we've developed this comprehensive in-house pipeline for data annotations. Everyone here knows the importance of having very high quality labeled data. And we believe that having full control over the data annotation pipeline can help ensure the integrity of both training and validation data sets. So these steps include model development recipes, inspection cadence, and version control. And this goes above and beyond just what is required for FDA documentation, and really allows for auditing of each portion of model development, and so that we can all understand the decisions that were made at the time they were made. So first, for model development recipes, quote unquote, we have rigorous data ingestion checks, whether it's DICOM data or textual data, with auditing and Nines tools, which is an in-house labeling software program. And that allows us to, track labeling efficiency, labeling accuracy, by labeler. There's data partitioning, where we can either test on a completely independent data sets, which is really ideal, or at minimum have a 20% holdout for testing. Having vetted labeler agreements on initial validation sets is very important before proceeding with natural language processing on report labeling. And then having image label verification and generation. Finally, image modeling and validation. It's very important to have regular inspections on individual labeler annotations, ensuring that the tasks they were assigned to do have been understood, and that the labels are accurate and consistent. And then finally, for version control, for every labeling batch that we perform, we always make sure to first specify a versioned labeling guide, and all of those version labeling guides are stored with the data, as well as versioned labeling proposals that sets out clear goals to labelers in terms of expected inter and intra label agreements. And these version labeling guides and labeling proposals are really invaluable to track the history of the data, understand in depth how our data was annotated, and then understand how those annotations may have evolved over time. And so now we'll look at how we think about evaluating algorithms in the real world. So we're constantly evaluating our tech stack, including non-diagnostic algorithms, monitoring their performance, and checking for data drift in the clinic. And it's really important, I think, to have that full circle connection so that you can monitor. We are always careful to evaluate algorithms on diverse data sets and make sure that they work over different post-stratifications of the data, such as modality, year, site, region, territory, et cetera. An important aspect of algorithm performance is to monitor constantly core quality metrics of our clinic and check for unintentional implications of the total tech stack and how that translates directly into clinical practice. Some trackable clinic metrics that are supported with machine learning include turnaround times, whether it's mean, median, expiring SLAs, quality assurance, where there's shared learning opportunities, and working towards our goal of independent blinded second reads rather than just non-random QA. Number of reported addendums, number of critical findings, number of follow-ups. These are just some of the examples. And now we'll look at some of those in greater detail. So monitoring clinical quality metrics in the real world. We'll look at that first. So one thing I mentioned was follow-up recommendations. So we use NLP to carefully track the number of follow-ups recommended by modality and by radiologist, and have NLP to analyze reports. So for example, if the number of recommendations are increasing or are unnecessary, we could make real-time adjustments. Monitoring model performance in real time is something that we've done with, for example, a surge predictor and notification tool. So this tool can actually monitor the work list and can then send a message to the clinical team saying, hey, we're going to exceed, demand will exceed capacity, so we need to engage others in more capacity. And this is a very helpful tool for patient care that works in real time. At Nines, we really have a rigorous process for iterating our training and validation data sets with radiologists to obtain the best possible ground truth, and obviously with subspecialized radiologists. And we also test multiple model configurations with this data. And so Nines is able to trace back each of the steps that went into model development. Having reproducible data sets and baseline models are really essential to iteratively improving model performance over time. And this results in an auditable model development process, which, unlike deployed third-party models, which may go unchecked in the production setting. And finally, these are key to explaining model properties, model behaviors, and limitations to key stakeholders. So we also have to acknowledge the limits of different machine learning systems. And as we know, it's difficult for radiologists, at least the radiologists on this call, it's difficult to reach consensus on the definition of normal or negative. And therefore, it's hard to establish the consensus level necessary to label a valid validation set to properly assess model performance. And now let's look at several parts to proper data management, and we'll cover a few of these here. As we all know, access to large volumes of data is required for high quality machine learning, and really having deep content knowledge of all of the DICOM tags and textual data is really crucial to safely ensure that not only PHI, but also PII is stripped. So just an example, this is my toe x-ray, which is from a few years ago. It doesn't look so bad. I'm sure it's worse now. But there are literally hundreds of DICOM tags, as was discussed earlier. And it's important to know, which ones you actually need and which ones you don't, so that you can then safely strip all the ones you don't need and really understand the bare minimum of what you do need. And that helps to have a safer data set over time. It was mentioned in earlier sessions about burned-in images, and we know this routinely for ultrasound, nuclear medicine, many other modalities, key images, key objects, scan docs, protocol reports, dose reports, injector reports, and all types of post-processing. And while some of this is helpful, just having those raw series is really the most helpful. And these are a lot of the pitfalls to be aware of, including, if you're going to also deal with reports, being able to remove a PII or any technology names, any doctor names is also critically important, so that at the end of the day, the only thing you may have is a report that's in a language and then that's the only way to define it. Another way we safely handle data is by database renaming for confidentiality. And that's for any partners we work with. We believe it's important to rename partner databases. And we choose to name it by national parks. We encourage the use of model cards and promote commitment to really data diversity that was mentioned earlier. So not only data from large urban centers, but also rural community hospitals, and ensuring that there's a variety of pair mixes within different data sets. And for example, if we have data sets on the East Coast versus West Coast versus middle of the country, those are, and you can have independent test data sets if you have that approach. Which gets into data partitioning, which really spans training, test data, validation data sets by city, by region, by territory. And this can help avoid training errors with rigorous inspection of DICOM tags and loss of function models, because you absolutely have to make sure that that same patient, cannot be in a training set and in a test set. So in summary, we've covered a few topics, including algorithm development, our belief in a side-by-side working model to really engage radiologists to make tools that they need to drive clinical care now, ensuring that the approaches to integrity of ethical data curation and labeling, and finally concluding with proper data management. And I look forward to discussing these topics with my peers on the call. Thank you for your attention, and thanks to the NINES team, who really is an amazing group of people. And for those of you on the Stanford campus, NINES is across the street from the Cal train stop in Palo Alto, and feel free to stop by, only of course when Santa Clara County COVID laws allow. Thank you.
Okay. Thank you, Dr. Kagen, for a great presentation. And I'm gonna introduce the next speaker, Dr. Meltzer, who is going to talk about, does AI amplify our blind spots? Now, Dr. Meltzer has a very, 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 very long CV. But essentially, all you need to know is that she's my boss, and she's fantastic. She cares a lot about, nurturing talent, diversity, and inclusion. Is a strong advocate for women in radiology. And if it's okay with you, Dr. Meltzer, I'm going to shorten your bio because it's very, very long.
Please, please. Thank you, Dr. Gichoya. I have such respect for you that obviously I could not say no to being on this panel with you. And I very much enjoyed the prior two talks. I wanted to thank Dalla and the organizers for allowing me to speak today. So I'm going to talk a little bit about, does AI amplify our blind spots? So my disclosure is that I am not an informatician. I'm going to speak more from my perspective as a physician who's been very engaged in bias issues and diversity and inclusion officer at Emory. So, we've talked about statistical bias and having incomplete data sets. We know that's a huge issue. When we look at genomic databases, they're not very inclusive. A number of studies which we really rely on for decisions of care were not very inclusive. But I'm going to focus more on how social bias translates into care delivery and how it is so deeply embedded in medicine that it can really influence AI and algorithmic approaches. And this has to do with, whether we're talking about explicit biases, implicit biases, or probably even more importantly, systemic biases that are integrated into our society around social determinants of care and access to needs to keep people healthy, as well as how that translates in our medical systems. So I've often talked about the over-medicalization of race. So race is predominantly a social construct, and we know from the human genome, research that genetic differences among humans are very small and tend to be around geography and how populations move. So there are genes that are tend to be in some populations and obviously account for disease, sickle cell, other things. But we have over-interpreted race in terms of medical terms and in terms of genetic terms. We also pretty much, our language that we are taught from medical school on, how do you describe a patient? You immediately say their age, their gender, and their race or ethnicity. And that invites a lot of clinical bias from the beginning in decision-making that sort of clouds our judgment and has these implicit associations between socioeconomic status, likelihood of compliance with care, and perceived likelihood of the success of treatment. And what was really scary was in 2016, a PNAS study of medical students showed that medical students really thought there was truth to a lot of the myths underlying racial differences that are pertinent to healthcare, skin thickness, pain sensation, sense of smell. There was a recent paper during COVID that was found disturbing in that looked for an explanation. These were the early days of COVID, looked for an explanation as to why COVID had disproportionately affected Black communities and tested the hypothesis that was due to genetic differences in density of nasal ACE receptors. Sometimes you find things when you make unscientific hypotheses. And we do know, and here in Georgia, we do know that African Americans make up a large part of the population. They also disproportionately were affected in COVID, and the communities that may not have access to the ability to socially isolate, to work at home, to have access to care may differ in different parts of the country. So in California, the population that had the most difficulty with isolating were the Latinx community. So this translates into real care and is not race-based. So health disparities start in kids. In 2010, the American Academy of Pediatrics published a landmark report where they talked about the extensive, pervasive, and persistent disparities in pediatric healthcare delivery and quality. And that sort of persistent, pervasive nature is what we're talking about that's embedded into our health systems. I like to think of radiology and imaging as a key to health equity, to get appropriate and prompt diagnoses, treatment, steer non-invasive therapies. But we also see, and this is in a very large study of pediatric hospitals, that imaging isn't equally afforded when a child is brought into the emergency department for similar symptoms. And we see that transfer to adult care. And this is a study from my own institution where at our children's system, there was an extensive review of pediatric patients who had liver transplantation over a long period of time, and those then followed those patients who were transferred to adult care. And there was a markedly discrepant rate of death when they looked at the patients who were Black and white versus white. So health disparities persist. And this is from adult emergency department data showing when someone comes into the emergency room with similar symptoms, they are less likely to get advanced imaging if they're Black or Hispanic, particularly CT and MR versus white or Asian, and more likely to get ultrasound or X-ray rather than the advanced imaging that we associate with more definitive diagnoses in some cases. And how else does that play out on an interpersonal level in the clinical environment? This is a very interesting study that came out in 2016, where actors portrayed patients and their family, and physicians, or mostly white male physicians, were asked to communicate bad news to the patient and the family about the prognosis of the patient. And experienced physicians had a way of presenting that information, and their verbal communication was similar regardless of the perceived race, ethnicity of the patient. But the bias played out in body language. The white physicians are less likely to touch or make eye contact, more likely to stand by the door when they were dealing with a non-white patient. And what does that mean for trust? And it's not only a race issue. We know that LGBTQ population, particularly those who are transgender, are less likely to show up for exams, more likely to delay care, or worried about harassment, discrimination, not feeling valued, not feeling understood by the healthcare system. And this is very worrisome. Even obesity, overweight patients. We deal with overweight patients all the time, but in our society, health and thinness go very closely together. And physicians are not exempt from the bias. It's felt in the population at large, where physician attitudes tend to reflect that of the general population of a negative reaction toward obese patients, and patients feel that. It also has been shown with the implicit association test, which doesn't always translate into behaviors, but many of us associate health with absence of obesity, and that can result in discrimination care. Dr. McCradden had mentioned the race-based algorithms that amazingly are still in many of our health systems and used to calculate risk, whether it's heart failure risk. And a lot of these, most of them really do disadvantage the marginalized community. So, you know, it's sort of a reflection of disease prevalence and not really accounting in a proper way for social determinants of care, delayed access, et cetera. So heart failure risk, add 3 points for non-Black, and they end up being referred earlier for treatment. And the GFR is the one we hear most about. This is being addressed largely around the country by redoing that algorithm to take out the race, but there's many others that need to be examined. We're systematically examining them in our health system. They also pertain to risk of having a safe vaginal birth after cesarean, and a lower chance of success is predicted for Black and Hispanic patients through the way the algorithm is currently used. And it's likely not to be data-based. So I don't know how many of you may have read the book, Invisible Woman. I found this very interesting. Carolyn Perez talks about how really our world is designed around a standard default man. From the temperature of air conditioning in offices, to the way we design subway systems, to the height of shelves. As someone who's barely 5'2", I'm always encountering a lot of this, and have been given standard 70 kilogram man-based medication with side effects for someone of a much smaller size. The size of a brick. It's meant to be held in the hand. I can't quite get my hand around a brick. I need to hold it with 2 hands, and an iPhone. And voice recognition systems, while they include female voices, are usually not sex deaggregated and tend to have lower performance for women than men. And some of this is really inconvenient, some of it's deadly. So she also talks about cars designed around the body of a reference man, and most crash test studies are modeled on male anatomy and size, and women are much more likely to be injured in car crashes. What about, again, the absence of data? Dr. Perez talks about the absence of sex aggregated data. How about in this study, 130 FDA approved AI devices, very few of them reported sex, race, ethnicity disaggregated data. And also many are not looked at more than one site. So I'm going to quote Dr. Gichoya and Dr. Banerjee and other colleagues who were, the good thing about procrastinating and not finishing your talk till the last minute is that when an article pops up in social media that morning, you can put it in your talk. And this work being done that shows standard deep learning models can predict race from medical images. And look forward to maybe hearing from Dr. Gichoya in the question and answer session about this work. But this is worrisome that our bias is in all that we use to create algorithms. The Sobermeyer study was referred to by Dr. McCradden, in which race, while not in the data put into the algorithm, was figured by other proxies that tend to go societal based with race, and referred Black patients to a risk prevention program or disease maintenance program at a higher burden of disease than whites. And what we don't all think about is the lack of diversity in the medical and tech workforce overall. There's a lot of work that's been done to try to promote interest in information technology and AI, machine learning professions, but they're not very diverse, nor is medicine. So what can we do? There's a lot that needs to be done. It used to be just thinking about making sure we had diversity in our data set, increasing transparency of the data set. But these algorithms are getting so sophisticated, and it's going to be harder and harder to tell how race, gender, other factors are being used and ending up in the outcomes. And I do believe that the greater diversity we have in our workforce overall, the more likely that we are to not translate lopsided bias into our algorithms. So lots more to be done. I'll just leave you all with a Marie Curie quote: "One never notices what has been done. One can only see what remains to be done." So lots of progress, still lots to be done. Thank you.
Great talk, Dr. Meltzer. And I see lots of questions coming through the Slido forum. So keep them coming. I think we're going to have a great panel discussion. So to our last presenter, Dr. London, who is going to speak on an ethical case for transparency in AI. If it's okay, Dr. London, I'm going to just shorten your bio. So Dr. London is the Clara West Professor of Ethics and Philosophy and Director of the Center of Ethics and Policy at Carnegie Mellon University. He has a book for the common good and has done a lot of work, written lots of papers, and done a lot of surveys, specifically looking at the nature of algorithmic bias, relative value of explainability and verifiability, ethical challenges in system development and deployment. He is an ethics expert and a consultant in multiple national and international organizations, and I look forward to his talk. Welcome, Dr. London.
Thank you very much, and thank you for having me. And it's a real honor to be part of such a great session. I was asked to talk about the ethical case for transparency in AI. I want to start by putting that into a bit of context. So what we want out of innovation is to produce systems and practices and procedures that advance patient interests, make a responsible use of scarce resources, and improve health system performance. Ethics and regulation have an important role to play in this because we want to ensure that there's an innovation ecosystem that provides credible evidence and assurance that the development process is actually advancing those social goals. And part of that is ensuring that the parochial interests of the various parties who are a part of this development ecosystem are either constrained or aligned with these social goals. Now, transparency has an important role to play in preserving the integrity of the innovation ecosystem. And part of what I want to talk about is transparency about what? There's a lot of myopic focus in the AI literature on model transparency. And I think that's fine as far as it goes, but it doesn't go far enough. And too much emphasis on it can be both misleading and dangerous. And so I'll say something about that towards the end of the talk. Here, I'm just going to echo some of the things that Dr. McCradden went over and say part of what we need is better transparency about the data that are really used to create these systems. And in particular, the methods that system developers are using to try to overcome challenges that are latent in their data. We need a much more transparency about the life cycle of development, including steps taken to have prospective validation of these systems, not just in silico, but in the real world. Very clear articulated criteria for the use case for which these systems are validated. And then also clear criteria for the window within which these systems will perform as advertised and outside of which they're likely to degrade or to break. So let me start with the importance of data transparency. And here I'm also going to build on a number of really important points that previous speakers made. You know, the AI models can do, machine learning models can do a lot of really, tremendous things. But they're really dependent on data. And in many ways, the algorithms that we build from the data are dumb in the sense that they can't necessarily separate out the signal from the noise, the arbitrary associations in the data, and the causally relevant things relevant to the pathology. So we need to know what techniques were used to try to avoid or mitigate the confounding that is pervasive in the kind of real world data that these systems are often built from. And so I'm going to talk about two issues in particular, one that's already been mentioned, so I'll just go over it very briefly, structural racism. And the second are just underlying quality issues in the data that we use to build some of these systems. So this paper by Vyas and colleagues has already been mentioned a couple of times. That's a good thing because it's an important paper. Just the important point that we're building systems on data that reflects disparities in social determinants of health that are often regarded as sort of biological facts about people. To the extent that we're going to build AI systems off the data from our health systems, and to the extent that our health systems are predicated on data like this, then we run the risk, as Dr. Meltzer said, of sort of recapitulating those underlying problems. There's specific issues, though, about the fitness for purpose of the clinical data that we have available to us. In most intervention development, we run clinical trials specifically to generate the kind of data that we need. So it's a real challenge to try to take the data that we have laying around and to squeeze out of them the kinds of information that we want to make diagnoses, prognoses, and or support intervention. So in this paper by Zek and colleagues, they noted that pneumonia screening convolutional neural networks that were trained on data from individual and even multiple hospital systems didn't consistently generalize to external sites, and nor did they make predictions exclusively based on the underlying pathology. And in the latter case, they noted really importantly that most image subregions contained features indicative of a radiograph's origin, or to other features of the hospital process or underlying clinical pathways or processes or practices that were associated with disease prevalence. And so that raises the question that in all the in silico training that we do, that part of the accuracy or reliability of the algorithm that we see in that setting would evaporate in the real world because it's leveraging sort of spurious associations that are latent in the data set that we use to train. And even, right, those associations can be shot through the many data sets that we use to create these systems. This is another example, so that paper is a few years old already. So Dr. McCradden said, well, we all know this. And I would like to think that we all know this. Here's a paper still in preprint, basically looking at X-rays to diagnose COVID-19 and seeing, well, how much of the validity or how much of the accuracy of those systems could be recovered if you blotted out, the clinically meaningful portion of the X-ray and just use the periphery. And it turns out a substantial portion of that could be recovered just from the periphery of the image. So here's a systematic review of some of that work by Roberts and colleagues. And they say many of the papers use the pneumonia data set from Carnegie et al. As a control group. They commonly fail to mention that this consists of pediatric patients aged between 1 and 5, developing a model using patients with COVID-19 and very young patients with pneumonia is likely to overperform as it's merely detecting children versus adults. So this is a sort of a real concrete example of a spurious association that's in the data that could contribute to really strong results in silico, but that wouldn't necessarily be represented in actual or replicated in clinical practice. So in a lot of the papers where you see very high, accuracy reported, those claims are in sort of sharp contrast with the claims of the people who review the literature. They say in their current reported form, none of the machine learning models included in this review are likely candidates for clinical translation for the diagnosis or prognosis of COVID-19. Okay, so this takes us to the importance of having a clearer sense of what the life cycle is for the actual development process and validation of our system. So this is a very busy slide and I don't expect you to go through all the details. This is just what I want to convey here is that when we're doing drug development, we have a messy iterative process where before we do a lot of preclinical work that's not in humans, but then we do a bunch of clinical work in humans that are exploratory trials where we're refining our intervention, the dose, the schedule, contraindications and so on. And we do a lot of that work before we then do critical confirmatory trials in people. In the life cycle of AI development, it's often very different. So here are 2 review articles. Eric Tobel is lead author on one, he's an author on the other, and you'll hear from him later today. But both of these papers talk about how few prospective trials there are in the AI space, that performance measures are not clearly linked to meaningful clinical outcomes. So there's a gap between the performance measures used to talk about the merits of these systems in publications and the performance measures that clinicians and caregivers would need in order to actually use them to clinical benefit. Many of these studies have a high risk of bias, and they note that 7 of the 81 studies that were reviewed claimed, this is in the second paper, by the way, claimed that in the discussion that the algorithm could now be used in clinical practice, despite only 2 of the 7 having been tested prospectively in a real world setting. So there's a mismatch, I think, between the expectations now of what it takes in order to validate a system as being ready to go into the clinic and the verbiage that is relatively common in the AI space. The concern there is that the more hype that we have without merit, the greater there's a concern that stakeholders' interests aren't aligned with the production of systems that really advance the goals that we talked about earlier. And that can have a backlash of mistrust against what could otherwise potentially be a really important set of innovations. So how much is model transparency an important solution to this? Well, Zeka and colleagues note that the DenseNet that they used had over 7 million parameters, and that the methods that are available to interrogate which features are driving model predictions, remain inexact. So I think what I want to point out here for the purposes of this talk very briefly is just that explainability is a relationship between the ML model and the user. and that various measures of utility, including various measures of accuracy and things like that, there are a relationship between the ML model and the world. And we have to be very careful to not think that explainability can be a bridge in between the gap between the model and the world. I had some slides that were that would dramatize that point, that rely on a very common example about diagnosing patients, predicting pneumonia from medical records. And the point about that is, if this is a patient who has pneumonia and asthma, and this is a patient who has pneumonia but no asthma, what you would think is that the patient with asthma and pneumonia is at a much higher probability of death than the patient without the asthma. And what some of these systems found that Caruano and colleagues were looking at, some of these systems said, oh no, the patient with asthma is at a lower probability of death. And they said that's not right. And so the transparency of the system is good. It should allow us to go in and open it up and maybe change the value on asthmatic there and improve the value of the system. And so this is an example of trying to use explainability as a way to try to bridge that gap. And part of the problem here is that when that system was trained, there was a bunch of other care that wasn't in the data that was used to train the system. And so the system was validated to make a prediction, and that prediction was actuarially correct, right? The probability of death, given the measured variables and all the other stuff that wasn't measured, was accurate. That hospital system was doing a much better job for treating asthmatic patients than for treating other patients. So that actuarially correct system, though, doesn't tell you how to intervene. And that's really what these people wanted to know, because that's what we want to do in medicine. So they wanted to know something like, what's the probability of death given no treatment, or the probability of death given some treatment that isn't the standard of practice. But that's not what those systems were actually trained to do. The data couldn't support that. And so my worry is that there's a danger here that transparency can encourage the misuse of systems. We saw the Overmeyer study earlier, and there's a lot going on with that study. And I think one of the things, though, is that risk in the domain of cost isn't a good guide to risk in the domain of disease. And so the idea that you can have a system that predicts in one area and then it'd be actuarially correct doesn't mean then that it's a good guide to predictions in the other domain, especially because the predictions in disease were not merely predictions, they were also meant to be an intervention. They meant to be, if we can now change, intervene in a way to help patients. And part of the problem is the risk score in domain of cost isn't a good guide to what is likely to happen, not just if we do what we did before, but if we change what we're doing. So my point here is that I think understanding an AI's model isn't necessary or sufficient for accountability. Medicine has a lot of examples of treatments that are where we have established through prospective validation the empirical merits of the intervention. Aspirin and lithium are good examples, but we don't know the mechanisms through which they work, and that doesn't prohibit us from using them, faithfully in clinical practice. Interventions can work before we know how they work. That's one of the unique features of medicine. And a lot of the reasons why we think things work turn out not to be correct. So I'll just mention here that 9 out of every 10 drugs that we put into a clinical trial, we spend billions of dollars on their development. 9 out of 10 fail to win approval for any indication. So in conclusion, then I think what we need to encourage are prospective trials in clinical settings to really validate the merits for these systems. Those validations should be done against clinically meaningful endpoints. We should evaluate systems relative to the best alternative. We should identify the conditions within which those systems perform well and outside of which they'll degrade, delineate the practices necessary to maintain those conditions in actual practice. And then we need an institutional culture that doesn't reward hype, that encourages long-term development, and that will discourage the use of AI ML systems outside of their validated indications. Thanks very much. I'm really looking forward to our discussion.
Thank you very much. I mean, these are really, really good talks. So what I usually advise everyone, and this is also personal advice, is just go back and rewatch. There's just a lot of content. There's a content thinking about regulation. There's thinking about training. There's actually thinking about how to do this work. And so, and it's also reflected in the questions that we're seeing online. Now, we have 30 minutes, actually less than 30 minutes for questions. So I will use the voting system to bump up the questions that are going to be answered. So if you like a question that's been asked, please give a thumbs up. And so the top most voted question so far is a question that asks, given the lack of equitable distribution of drinking water, for example, in Flint, Michigan, in the US, and many places worldwide, how can we ensure the equitable sharing of data to advance medical knowledge for all populations? And there's a related question that I'll follow up with. Any takers?
Sure,
I'm also very good at pinpointing people. So, yes, Dr. McCradden.
Yeah, I think that's a really excellent point. And one of the things that I didn't actually mention, an additional moral commitment of clinicians is that of advocacy and advocating. And so the data, having that knowledge, having the data is sort of the first step to targeting some of that advocacy. We see that, for example, in the white coat die-ins in protest of systemic racism. So I think that having that data is that first step, but really the advocacy lies with clinicians to really identify the areas where equity can be achieved for individuals.
Awesome. Any other reactions to this question?
I might just add that, I think radiologists are now realizing the role that they need to play in health equity and in communities. And I think overall, COVID has had a distribution that has been so glaringly biased in our society that many health systems and many physicians who thought, this isn't part of my role, I just treat my patients, are realizing that the advocacy piece Dr. McCradden talks about is vital and that we have to be part of the solution.
Okay, great. One of the sort of questions that's coming up here is, great talks. Why is blockchain or smart contract structure not used for anonymizing and sharing the data? They can also help startups to get more data for training their models. I think this is a good question for Alex, because you're doing a lot of, sort of this type of infrastructure, and I'm curious to your answer to this.
Yeah, I think it's a great question, and it was somewhat reviewed in the last session. And data sharing is something that institutions, like Scott mentioned, have a policy around it. And I think standardizing policies of data sharing kind of nationwide is really what's needed, so that folks are not kind of asking one institution versus another, which is what historically happened in the past. And then there are limited data use agreements. They really need to be broad. And as Dr. Meltzer said earlier, we have to advocate the need for this. We as radiologists need to advocate to our patients and say why we need to be able to share data with each other and pay it forward, to coin the term that was used last session.
Okay. Melissa, there's a question for you. Patients do better when matched ethnically to physicians. I think we've seen several papers that show this, and this could be due to patients' engagement bias or physicians' lack of cultural understanding. So measured provider data seems insufficient for fair AI development. So where is the balance for fair AI development?
Yeah, that's a really great point. And that's actually something that we've explored in our context here at Sick Kids as well, in terms of looking at race or gender concordance for being associated with patient satisfaction or patient care. And I think what's really notable about that is that it operates on a number of different fronts. So it's not simply about, perhaps better care, but it's also about the patient experience. We hear this from parents. My child can see a person who looks like them in this role, and they maybe haven't seen that before, and they maybe don't see it elsewhere. And so regardless of whether we think that it's about a particular kind of knowledge that is relevant in that encounter, or whether it is about, understanding a certain shared experience, which may or may not actually be shared between a provider and a patient, there certainly is something there. And I think, a basic kind of tenet of something like standpoint epistemology recognizes that the quality of our science is better when we have more standpoints, we have more viewpoints by which to view the problem.
Do you know that, what's your reaction towards, you say like people understand the science and we're moving the science there, but also in the bigger context of seeing the last, 18 months is that there's also quite a lot of disbelief in science, and fight against science. How do you sort of balance that and, convince the public and the patients who are really involved in these initiatives that this is the right thing and how they can get engaged?
Gosh, that's a good one. Yeah, I think it's not so much about convincing, because if we look to the research looking at social license surrounding the use of health data, universally we see that there is a strong, consistent majority that is supportive of health data sharing, that is supportive of the use under certain conditions. So for example, non-monetization being the biggest one, but we also know that there's a consistent group that is not okay with it. And I think we all know that group. There are particular individuals who have been systemically, historically disadvantaged by medical institutions. And so there's a very high level of distrust. And so I think it's not so much about convincing them that they should trust us, but demonstrating, as many others have said, it's about demonstrating our trustworthiness. And I don't think that we can do that through showing we're going to do good AI alone. I think we also have to do that through promoting patient safety, cultural safety, and anti-racism within healthcare institutions.
Awesome. Dr. Kagen, how does the industry perspective on and commercial needs related to ethical AI complement the public health and health system perspectives? In what ways might they not be as well aligned?
I just want to follow up to what Melissa said and maybe what Alex mentioned earlier, that, if we're looking at and we're building algorithms based on historical data, which is inherently biased, we not only is it biased in terms of race, but also in scanner modality, right? I mean, if you had a bunch of Toshiba CT scanners and now you don't have Toshiba anymore, it may be biased in that sense. So we're going to need constantly evolving iterations of data as equipment changes, as people change. So I do think that I just wanted to make that point of how we really need to play a role in advocacy so that we could get people used to, requiring constantly new sets of data. And in terms of industry, I would say if you're kind of vertically integrated and your overall goal is the best possible patient care, then it kind of then I think the goals are aligned with public health. So if you're producing, amazing radiology reports and you're an amazing radiologist, then and you're more efficient with all these tech tools, then that's still aligned with public health, rather than if you're only just building software and kind of going from customer to customer.
So let me just ask a follow-up question towards this. So, Dr. Kagen, we know that as researchers here at Emory, thanks to Dr. Meltzer, we have actually quite a lot of support to do AI work. But the reality is that the data sets that are there are not the same. We know that private companies can purchase data. The regulation, the regulations tend to be honest, lower. They are able to match this data in, things that where people, if they knew about what amount of record linkage would be very concerned. And this data not even exposed to research. So not necessarily to you, but to the panelists, how do we get this sort of a place and incentives for where we have social good for everyone?
I think, considering it like water, like it was in the last panel, is where we need to get to, and having standardized ways of how we de-identify, because the more you strip, kind of the less as we try to be as protective as possible to patients, the less information you have, and you lose kind of diversity in your data set. So just, I think, having standard ways, really standardized approaches to everything, but having standard ways to de-identify not only DICOM data, but places that have a clinical arm are going to have much better access to all the EMR reports that you need. And so, for example, at Mount Sinai, we have a whole arm of data scientists who actually anonymize not only image data, but also report data, EMR data. And so having, I think, kind of following the centers that have done that and kind of standardize that nationwide is what needs to be done.
Okay. Other panelists, do we have reactions to these issues being raised?
I would just add that I think it's important to move beyond the idea of access to data and more data, because more bad data isn't going to be good. And a lot of the data that we have available to us was created for purposes other than what we're trying to use them for. They were created for billing purposes. So much of the data, the clinical record may be lost and homogenized because the purpose for which it was created, for billing or something else, it doesn't need the kind of bandwidth of data that we would need to develop an AI tool that's being used for clinical purpose. So I think part of the change needs to be, we've got to gather data at the right grain size, specifically for the questions that we're trying to ask or answer, rather than, when you have to live with certain data and then build models from it, you do your best you can. But that's not a good strategy going forward. We need to figure out the questions we want to answer, like the high priority questions. And we need to get the data that's going to be good quality at the right grain size to answer those questions, and then make that available.
Melissa?
Yeah, thank you. Just to add to Professor London's point there as well, I think many have pointed to regulation as being the mechanism by which we can achieve some of these things, such as safety. There's a really great paper out quite recently, actually, looking at regulatory standards for AI algorithms and demonstrating really that actually there's a lot of vulnerability here. And so, I always come back to this idea, like the proof is in the pudding, and you have got to prove the benefit. And it doesn't necessarily matter. Some of the specific details about the algorithm itself matter a lot less than the actual demonstration that it can provide benefit to patients. And that's where I think, I feel like we should put a lot more focus into that aspect of this AI cycle.
Okay. Awesome. I have a question for Dr. Meltzer. Since you're still my boss, I'm not going to call you Caroline, but,
okay.
Recently I had to go to the hospital, and in Atlanta, we have very bad traffic. And, there was a very bad accident, and I got late. But in the medical record, I was labeled as non-compliant, no-show, which this is something that most people will relate to, especially most people of color. Unfortunately, we've looked at this, we've looked at the EHR. So how do you, much as we're saying, let's collect proper data, how do we balance these structural racism issues and institutional racism that already exists that affects how we provide care? For example, more people are likely to to do a drug screen for someone like me when I come to the ER more than someone like you. So how do we do this, thinking about the bigger society?
Yeah, it's so deep. You're touching on incredible points. And I'll just regress for a moment to, there was a Seinfeld once that was very sort of tongue in cheek, but talked about once you're labeled a bad patient, what happens to you in the healthcare system. And yes, we do have these strong associations, and the algorithms that we use to predict no-shows have all this in it. But who do we design our systems for? How do we determine that we're building more parking lots as opposed to transportation that's accessible for all of our population? So some of this is so deeply embedded in society, and also in the lack of diversity for us to share creative ideas in the medical community and in any business, where we say, oh, but for, the community I work with over here, this wouldn't work. Or here, traffic patterns, are XYZ, or who's taking what, but they're not that sophisticated. And they're often predictive about things ancillary that then reinforce our biases as providers. So I wish I had a great answer, but it takes looking at these and takes that equity-minded lens to look at every policy, every algorithm, everything we do.
Okay, thank you. There's a comment from Jose. There's no such thing as bad data. The data is fit for use or not. Those qualification of bad or good data does not encourage the people that generate and maintain the systems that make the data available for primary and secondary use. We are coming close to the 10 minutes, and one of the things about ethics is that sometimes we feel like those things are up in the air, we don't really know what we're supposed to do with things. Dr. Meltzer is trying to point to one of our papers that it's not peer reviewed yet, and we actually found this I think out of the world finding that the medical AI algorithms can detect self-reported race from medical imaging. And it's interesting to look at the comments on the social media towards this paper. There are a lot of racist comments. I'm just going to say it out loud there. But, I've also gotten lots of messages from my colleagues. And one of the things that came up is, should we even do this work? In fact, one of my close friends said, well, I kind of looked at this more than a year ago, and I felt that it's unethical to ask this question because it shouldn't be asked by a white male in their basement, and they shouldn't be done alone. So can we have comments from the panelists on how do we create safe places to do this type of hard work, and also a reaction? Should we be asking these questions or not? I'll cherry pick. Dr. London.
Yeah, I think, as you put it, there's a fine line here, right? Because there's both what's the quality of are we doing quality of science, and our record with race adjustment in algorithms is a real indictment of the degree to which we've sort of been pretty happy to just say, okay, this is the way I see a bunch of people in a particular class present to me, I'm going to assume that that's their base rate or their baseline. And so being more circumspect about to what degree are the very common associations we might see across a group part of their biology, or part of the way that the social determinants of health impact their biology, is really critical. It's critical in clinical trials because we record race of people in clinical trials, but as Dr. Meltzer was saying, race isn't a biological construct, and it's still important because it's often proxy for many other features of people in a clinical trial that could determine differential reaction to a drug, because there's differential rates of diabetes or heart disease or underlying comorbidities and stuff. So I think it's important that we look at these things, and also that we look at them in a broader perspective, not just as biology, but as to what extent are these things the cause of biological causes, and to what degree are they the effects of social inequalities?
Okay, Alex.
And absolutely, we should be doing this work. We shouldn't shy away from it. We should absolutely be doing it. I think the point of what you made earlier about no show or late. There's so many things that are structurally racist, including it may come from accessoride for people who need rides to the hospital to make those appointments. So 100%, I think we do need to be looking at all of our data and checking for inherent bias within it.
Awesome. Melissa, do you have any comments?
Yeah, I think that's a really good point. And I think that, the recent controversy in the past year surrounding Timnit Jabru, for example, has really highlighted that you cannot just expect people who are marginalized to carry all of the burden of this work. because they are often silenced. They are not provided with a safe environment in which to do that work. And so I think it's not just a matter of, getting the numbers right of people in a particular space. It's about truly fostering a culture of safety. And even within the field of bioethics, people like Dr. Keisha Ray have noted how even ethics traditionally has othered issues of things like racial justice. And so bringing those into the core of what we do, rather than having them as this other consideration that, oh yeah, we also have to think about that. I think that's really the key to sustaining that change, because I've heard from other people as well who have really questioned, what are we doing here? Are we doing good? Is this right? And I think those are really important questions to ask. And those are all the people that I really want to work with. Because I find, that level of questioning and that level of self-reflection, I think is really going to be needed going forward.
Awesome. Dr. Meltzer?
Yeah, I agree with many of the comments. This is about everyone's work, and it's a journey. And we've got to have adopt a culturally humble approach to all in. It's not okay to not look at the data for certain biases, or, we have to look and we have to understand it better. And definitely for all in.
We have a compliment from Audrey, who says, such a fantastic discussion. Thank you for this great session and calling out the need to be anti-racist. I think everyone now knows you just can't be a bystander. You're either, and intentional in data collection, data use, and data application. There's a question for Dr. London. The lack of performance monitoring for AI programs in a clinical setting is worrying. There are laws addressing physician mistakes, but none for AI programs. What do you think can be done to minimize this gap?
So I think we're really lagging behind there, especially since I think we have to do a better job of distinguishing what are features of the world that are natural, in the sense that they're likely to be there and remain there if we implement our AI system, and what are the features of the world that are going to change when we implement our AI system. And this is important for radiology, because that finding from the Zech paper, that even in small portions of the radiograph, you could identify things like what brand of machine, whether it was a portable machine, which unit it came from, which hospital it came from. Well, when you implement your algorithm, those things are going to change. And if the performance that you're expecting drops off a cliff as a result, we need to be able to know that, detect that in real time. And then like all software, we got to make sure then that the things that we do in response to that improve it rather than introduce more problems, right? So there's a lot, medicine is a dynamical system. And there's a lot right now, because so much of the AI literature is sort of in silico, there isn't as much confronting how you're going to have maintained performance over the long run in the face of dynamic changes, not just given conditional on implementing the system, but in other places, in the clinical practice, improvements in other parts of clinical practice that feed into that, either as data or other parts of patient care.
Do you think IRBs are ready for this challenge? Like, for real, do we think that IRBs can take this challenge?
I think it requires collaboration. Like, that's something that we've really noticed. That the chair of our REB and myself really worked hard to implement our pathway. And it was so critical that we had our team of data scientists available, because they can identify risks that that the traditional team would not be able to identify, but also it enables this ability to adapt where it is reasonable without throwing the whole model out. And so I think really thinking about what we keep as part of that ethics review to protect patients, to protect participants, but also adapting for a new kind of methodology that is coming forward.
Awesome. Any other comments? No. Okay. So we have 2 minutes for people in the West Coast to have lunch. We already had lunch in the East Coast here, but we will spend the next 1 minute leaving with final words, hopefully more optimistic, and just something that you're excited about, or this is just a random spiel for like maybe 15 seconds. Dr. Kagen, you go first.
So I just thank you for moderating such a great session. Thanks to all the panelists. I would say that as we see data changing over time, we're lucky enough to have young trainees who are passionate about diversity and passionate about equity. And it's wonderful to have those folks kind of driving the changes that we need to make.
Dr. Meltzer?
Yeah, I'd also like to add my thanks. A great session, Judy, and pleasure to be here with all of you. I think the fact that we're having these conversations with ethicists, with data scientists, with physicians, with people who have DEI expertise, I think that conversation needs to go forward and guide us. We don't want to turn out algorithms that don't help promote better outcomes. So we have to define where the endpoint is in medicine. Thank you so much.
Dr. London?
Well, yeah, also thanks to you, Dr. Gichoya, for moderating a great session. And yeah, I think the thing I would end with is we have to move beyond focusing on the algorithm itself to the whole picture of what is the system into which this, the larger social system into which this system would be placed, what are the right comparators so that we know that this is a clinically meaningful improvement. And we're really not, in many ways, we're not there yet. We're sort of at proof of concept, and we need to move, the path of clinical development for AI systems more robustly into showing what I think people want, which is comparative effectiveness, right? This is better in the real world than the alternative.
Wow. I agree with that. This would have been my final words in a few years to come. So, Dr. McCradden.
Thank you. Yeah, I'll echo my thanks as well to the other folks. This has been really fantastic, and I've learned a lot from all of you. And I think something that I often reflect on as kind of final words are Dr. Ruha Benjamin's words, which is, once we recognize that we are pattern makers, we can change those patterns. And I think it's incumbent upon all of us to do that work inside and outside of the AI space to really kind of change the structure of our society to really facilitate equity.
Awesome. Thank you so much for your participation, your presentation. If you're listening to this, I encourage you again to go watch the recording. There's a lot of content that was discussed in the last 75 minutes. We thank you for your time. The hard work begins now. There's a lot of work to be done, and we appreciate you. Thank you very much.